Hi, everyone. I'm Dr. Naveen Pemmaraju, Associate Professor of Leukemia and the Director of the Program for Blastic Plasmacytoid Dendritic Cell Neoplasm, or BPDCN, here at MD Anderson Cancer Center in Houston, Texas. And I'm proud to be a member of the JIPO team, along with Professor Ong Nang and our colleagues, and really had the chance to do an inaugural special issue of rare hematologic malignancies, focus on rare blood cancers, and looking forward to discussing that with you. With this rare hematologic malignancy, blastic plasmacytoid dendritic cell neoplasm, or BPDCN, have really had no standard therapies up until a few years ago. The big breakthrough in our field for patients with these diseases, they're like a rare acute leukemia subset, was that the cancer cells uniformly express a target called CD123, or IL-3 receptor alpha. So that finding was there. And then a second leg of this was that there was a drug in active development targeting specifically this CD123. So I had the fortune of being able to lead the pivotal registrational study for this drug, SL401, or tagraxofus, which ultimately resulted in New England Journal of Medicine paper for me and my group 2.5 years ago, and US FDA approval for ages 2 and older, and now importantly, EU frontline adult approval for this agent. One other aspect of CD123 is there are many other drugs now in active development, including the IMGN 632, which is another CD123 targeting agent, which I am helping to lead those efforts, and we presented that at the ASH meeting 1 year ago. Mm-hmm. Yeah, another exciting aspect of putting together this issue was thinking about other rare leukemia and hematologic malignant subtypes, and one of those is the MPNs, myeloproliferative neoplasms, used to be known as MPDs, or disorders. So among MPNs, the most aggressive and clinically most difficult for our patients is myelofibrosis. There, kind of a similar story to some of the other rare blood cancers, there's really only one approved class of drugs, and those are called JAK inhibitors. So JAK is an intracellular target that helps to govern sort of self-differentiation in these blood cancer patients in those cells. And these drugs have been highly effective, but don't lead to cure of the myelofibrosis by itself. And so we're trying to highlight the burgeoning or emerging area of clinical trials beyond JAK inhibitors, which include a lot of different classes, but just to name a few: BCL-XL inhibition, so working on the level of the mitochondria, apoptosis; bromodomain inhibition; hypomethylator; IMiDs; PI3 kinase, so on and so forth. So there's a bunch of different targets now that either combine to synergize with the JAK inhibitor, or after the JAK inhibitor has stopped working, to go beyond that. Yeah, and so yet another one of these rare hematologic malignancies that's getting spotlight by our groups and others is CMML, chronic myelomonocytic leukemia. And my colleagues here at MD Anderson, led by Dr. Garcia-Manero, Dr. Montalban Bravo, our pathologists, with Dr. Khoury and Lagavi and many others, have been working on this rare disease subtype. The bottom line is that CMML is a heterogeneous disease. That means that there's not just one for every patient. So it's been classified under myelodysplastic syndrome, then MDS-MPN overlap syndrome, and now maybe its own separate category in the future classifications. So yeah, there are a couple of different molecular mutations and drivers, mainly centered around what you would see in some of the more aggressive myeloid malignancy subtypes. So ASXL1, for example, is just one of many molecular targets that we're seeing. The other concept in CMML is, again, the same theme you're hearing, is that there's really only one approved class of drugs there, which is the hypomethylator agents, azacitidine and decitabine. And most of that data had been derived from the cousin disease, MDS. And so now what you're seeing, again, that's what we're trying to highlight here, is that these rare diseases are starting to have their own investigator lab groups, their own dedicated clinical trials, and their own targets, which is exactly what you're bringing out nicely in this interview. And I hope that people will find that to be of interest as they read our special issue. Yeah, so CAR T therapy is maybe one of the most exciting areas for our patients and scientists and investigators in the last 20 years. So basically, this is immune modulated or genetically engineered therapy that allows trained T cells or other cells, NK cells for that matter, to now go after specific targets in cancer. The amazing part about it is it kind of went from an idea on paper in the lab, science fiction, if you will, 20 years ago, to then the early clinical trials. And to my amazement, already now into the FDA approved community setting, all of this in just the last 10 years. Right, so these CAR Ts have gone into the clinic in the real world setting, lymphoma, leukemia, some of the early disease types. And basically, it's been an amazing experience, right? So for this high level type of therapy to be out there, centers have to be accredited. So that's a separate process. Patients have to be safe enough to get it. And then centers have to deal with the side effects and toxicities. So it's actually been a very amazing, overwhelming experience worldwide, for these CAR Ts to be given. Two or three of the issues that are coming up is, as always with any clinical trials, patients in the real world are often sicker, they're older, they have more comorbidities, they have maybe central nervous system disease. I mean, there's a lot of things that are going on in these patients that may not have been seen in the clinical trial. So my colleague, Dr. Loretta Nastapol, and her team here at MD Anderson, Dr. Nilapu and others, have been at the forefront of collecting this data. And in our special issue, we delve into that. And actually, it's not all bad news. It actually shows the extension of these CAR Ts in a way that could not have been studied on the rigorous clinical trials. And I think people will conclude that actually you can give these CAR Ts to even a wider variety of people than was first ascertained.